So good evening, everybody. So on behalf of Council for Ayurveda Research, we welcome you all on the Journal Club meeting. Today's our presenter is Dr. Jay. Dr. Professor Jaygopal Parla is an internationally renowned speaker, educator, and practitioner of Ayurvedic medicines and yoga with extensive clinical teaching and research experience. And Professor Palla holds a Bachelor of Ayurvedic Medicine and Surgery from Bangalore University, India, and a master degree in Ayurvedic medicine with a specialty in herbal medicine from Rajiv Gandhi University of Health Science, India. He also graduated from Master of Acupuncture and Oriental Medicine program at Southern California University of Health Science. He is a certified yoga therapist and completed a yoga teacher training program at the Bihar School of Yoga. And he is a professor of Ayurveda at the American University of Complementary Medicine, founder and director of Atre Ayurvedic Integrative Health Center, Long Beach, and founder and vice president of Atre Herbs, a US based provider of Ayurvedic herbal formulations. He also teaches at Southern California University of Health Science, Mount Madonna College of Ayurveda, and Kerala Ayurveda Academy, and serves as a visiting faculty member at the Japan School of Ayurvedic Medicine. So, on behalf of Council for Ayurveda Research Journal Club, I welcome you, Dr. Vaidya Parla. Please present your presentation. Thank you so much.
Thank you. And namaste to everyone who is listening to this presentation. And I want to thank Council for Ayurvedic Research and the members and the founder, Dr. Pratibha, Dr. Meenakshi, and Dr. Vandana, who are here on this presentation. This has been a wonderful opportunity for me. And I wanted to share this unique study where this study kind of gives a frustration that an Ayurvedic researcher would face with the type of research methodology that we come across, which is kind of bought from another system, like the modern research methodologies that we are trying to apply for the Ayurvedic studies. In this study, which I have chosen, I want to highlight those shortcomings that we face when we are doing an Ayurvedic research, and how there are different scientific, not only scientific, but also evidence-based new methodology is being inculcated into CAM research. So that's what I would like to highlight in this presentation. Okay, so first thing is that about the declaration. So this presentation is done purely for academic purposes to understand the methodology or methods for critically appraising a scientific manuscript. It by no means intends to harm or criticize the investigators or any other person or personnel connected to the manuscript or to this clinical study. So I want to be very clear in that. I'm not critiquing for something that's lacking in this study, but it is a process of learning and trying to improvise and get a greater hold on the methods of research needed for Ayurvedic science. The views expressed herewith are for the sole purpose of academia, right? And also the presenter declares I declare no conflict of interest in this presentation. Let's look at what is this study that we are up to today. So the first thing that I wanted to read out is the title of the study. It's a pretty long title, but it has those elements that we are looking for, the shortcomings I was saying, for Ayurvedic studies that we try to do for collecting the data, the scientific data for Ayurvedic research. So let's look at the heading: a complex, multi-herbal regimen based on Ayurvedic or Ayurveda medicine for the management of hepatic cirrhosis complicated by ascites. So the category of this study, the grouping is non-randomized, uncontrolled, single group, open label observational clinical study. So you can see that these types of studies are always happening in Ayurvedic institutions because in my personal view, a RCT is a harder study to do because of many hindrances that we come across. So when I say, simple example would be in doing an RCT, producing a placebo. Placebo can be very difficult if you're doing, let's say, a panchakarma procedure and you're comparing it with, a control study, a control group, interventional group, and a standard group or something. To do those placebos, it's very, very difficult. So that's one of the shortcomings. So it's like that. Being Ayurvedic fraternity or Ayurvedic scholars, we have to find ways around to see how we can achieve and establish a valuable data during our scientific, research or observation. Okay, so that will be the study that we will be going through. So what is the objective of this study that the authors try to, by the way, the authors are Patel et al. So it's done in Nanded College in Maharashtra. And also it has good collaboration of multiple scholars, not only from India, but also from Europe and US. So that's the strength of this study, because it's been looked upon by multiple scholars and very well published. So one point that I wanted to bring here is, if you do a study with a real good methodology, even though there are shortcomings, because the gold standard for any study in modern science is the RCT, which we call as randomized controlled trial. So it's a gold standard, and that may not be gold standard for Ayurvedic studies at times, right? So if the study is done with real good methodology, not necessarily it is an RCT, like this is a non-RCT study, but in the discussion and conclusion, right, in the discussion part and the conclusion part, if the authors can conclude with a proper, very clear conclusions and discussions, if it is done, then that study carries a lot of value. That's what we are going to see in the study, that is which objective of this study is to evaluate the general potential of Ayurvedic therapy for overall clinical outcomes in hepatic cirrhosis complicated by ascites. So it's not a simple cases that these researchers are handling. There are the short term, the acronym that they are using is HCCA. So which is for whenever we mention HCCA, it is the hepatic cirrhosis complicated with ascites. That's what is the acronym standing in there for. So what are the methods? So it is a single-centered study. As I mentioned earlier, it is done in the state of Maharashtra in an Ayurvedic college or an institution with both inpatient facility and an outpatient department. So that's how they have done it. So single-centered study, as I said, it's a non-randomized study. Then the sample that they have chosen is the hepatic cirrhosis complicated by ascites. Sample size, I will come to the sample size in a minute, because they initially started off with 68, what is that, sample size or participants. And later, because of some reasons, it reduced to 56 projected. So that's what the final conclusion of this study is, with 56 participants. It's a decent amount of participants being taken in this study. 56 is a good number. The intervention guidelines is based on two things. One is that there is a 6-week treatment period. And then what they have done is they have done a 18 weeks follow-up period as well. So one thing that I found in this study is that 6 weeks, treatment, another 18 weeks, which makes about 24 weeks of observation, or the trial itself, the extent of the trial. But at some point, the authors are saying that it's a 6-month study. Maybe it's 5.5 months rather than 6 months. Okay, so that's one thing that I found. Maybe there was a lapse which I did not understand, where there was a little gap between the treatment period and then the follow-up or something like that. But they mention it as 6 months follow-up study. Outcome measures, they are very clearly stated, and it is a very well documented study. I found that they have done really good parameters. They have chosen not only subjective parameters, they have also taken like objective and the laboratory investigation. So they have done it in later in this the interventions and results. I will go through those different interventions, that outcome measures these scholars have used. So here is the inclusion criteria. So what they did, the screening was done between, even though the study is published in 2015, so the initial screening started in 2007. So the entire study was done in 3-year span, right? So from 2007 to 2010, they collected all the data that they wanted. That it makes sense, because the nature of disease with a specific, hepatitis with complicated cirrhosis is, somewhat in the Ayurvedic fraternity or Ayurvedic, practice is, somewhat difficult to come by and maintain. So that makes sense that they have taken 3 years of data collection. Then they had age group, any adult, male or female, over the age of 18. That's what this had included. So the inclusion criteria was positive patient history and established diagnosis of the HCCA according to the international standards. Okay, so they have done the criteria of inclusion based on the modern pathological studies or modern clinical studies they have used. Even though they have said that it can be compared excuse me excuse me it can be compared to Jalodhara in let me get a sip of water, something got into my throat. The cases can be compared to Jalodhara in Ayurveda, but here they are calling it as HCCA. Manifesting clinical features, especially these clinical features they have taken, that is edema, which is generalized edema, but also specifically abdominal, like ascites. So the loss of appetite, general weakness, nausea, vomiting, increased measurement of abdominal girth, that is the sign of ascites, and then decreased urine output and the manifest laboratory findings. So they have taken the laboratory findings also into as parameters. Then the consent was taken from all the participants for collecting the data and publishing the data from the patients. Exclusion criteria, they did a very extensive exclusive criteria. As you can see, they said that if any hepatic cirrhosis that is a complication of a secondary disease like cardiac failure or a metabolic crisis that is causing the hepatitis and the cirrhosis was excluded. Then they also had Wilson's disease and also hemochromatosis. These two diseases they also did not take. Wilson's disease is an acute disease where there is a spontaneous hematemesis, blood vomiting. So Wilson's disease has been because of the nature in which the Ayurvedic hospitals are not able to handle such life-threatening conditions. They have not included them. Life-threatening complications like encephalopathy and then excessive gastrointestinal bleeding, like in Wilson's disease. Other major comorbidities like insulin dependent diabetes was excluded, bleeding piles. And in cirrhosis, one of the complications is either esophageal varices or the anal or the hemorrhoidal varices. These two were excluded. Manifest of heart disease, renal failure. And again, they also excluded some of the female participants if they are pregnant or they are post partum state having these conditions. They have excluded those. Liver damage due to medicine like iatrogenic diseases wherein the liver is involved, that was also not included. So very neatly categorized into inclusion exclusion criteria for the type of complex disease that they are trying to research. So the intervention is very interesting in this case, in this study. So what they did is they provided the standard care that is according to the Ayurvedic standard care that has been said in the classical textbooks that they have taken. And they have also done it as inpatient and outpatient. So the first, a part of the treatment is inpatient, which is first 7 weeks is the inpatient, and then they have done another remaining 18 weeks or something like that, which is the outpatient, observation or data collection. So the entire intervention is done in 4 phases. Let's look at each of these phases. So here are the a intervention phase, table that they have put together. So VO is the beginning of the study, or the baseline study. So they did all the clinical and laboratory investigations and then included recruited the patients who come under inclusion criteria. Because it's not a randomized control study, they took everybody who came under the inclusion criteria. Then the admission was done through the OPD, first through the OPD, and then they became an IPD patients, the inpatient department. So in the first phase, they gave the 1 week of Pipali. Then the second week until the 13th day. I'm sorry. Not 7 days. 13 days they did the prayoga of Pipali, and then they did the virechana, not virechana like a bedana, actually bedana process they did. That is on the day 14. And then phase 2. They consider the bedana treatment that they have done as phase 2 of the intervention. Phase 3 is a single herb administration. And phase 4 is the what they call as OPD, diet and lifestyle intervention. So that's how these 4 phases are done. Okay. So at the end, they have done 24 weeks of complete follow up for these cases. So, detail about the first phase of intervention. So, this includes use of Pippali, somewhat like Vardhamana Pippali Prayoga, where, according to the classical textbooks, we increase the Pippali as by a certain amount. Here they have done, they started with 1 gram on the first day, second day 2 grams, third day 3 grams, fourth day 4 grams. And then from fifth to ninth day, they kept 5 grams. Probably they have would have mentioned kana, how many Pippali kanas will make that, and they have measured it as 5 grams. I'm just guessing here. Could be that the authors in the literature don't mention anything about how they concluded this, 1 gram to 5 grams to 1 gram within 13 days is been not mentioned. So at the beginning of the IPD period, everybody, all the 68 participants were given the Pippali Prayoga, the administration of Piper Longum. And what they did is they were given this dosage twice daily, 2 times a day, with milk, like how the Anupana or the adjuvant that has been mentioned in the classical textbooks. So they have taken exactly the same, Anupana, and they have given this. So that was the phase 1. Then phase 2, that is after the 13 days of Vardhamana Pippali or Piper Longum being used, then they have done a prayoga of one single herb called as katuki or Picrorhiza curova. So this katuki is given anywhere between a dose of 3 grams to 6 grams. And they have said in the study, they have clearly mentioned, depending on the koshta, or they said that bowel movements, depending on the intensity of bowel movement, they have chosen some people to take 3 grams, some people to take 6 grams. So it was given on the 14th day, one single dose, and the people were said to expect a purging effect, or bowel movements in a liquidy form, right? Which is somewhat like not classical rechana or virechana. A bedana treatment has been chosen because katuki is taken as a bedana dravya. Even though it comes under the large category of virechanas, it is bedana dravya. So that's what the authors have done. They have taken one single dose of it, and they have administered this katuki prayoga. That is on phase 2, 1 day of katuki. Now phase 3, after the 14th day of purging, 15th day onwards, they have given the Punarnavashtaka Kashayam. So the not Punarnava, like single herb, but it is in a combination. So Punarnava, it has the following herbs, all in equal quantity. So Punarnava, Daru Haridra, Musta, Haridra, Nimba, Guduchi, Shunti, and Katuki. Again, Katuki also comes in here, but if the quantity is lesser. So they were administered about 40 ml of this the concoction, aqueous extract, what we call as decoction or kwata in Ayurveda, was administered to all the patients. So all the 68 patients received it, and later they say that all patients were able to tolerate some of it. They have a group that was not very tolerant to some things, but overall the method, different interventions that were given, everybody was able to tolerate in the sample group. So this was done from phase 3, right? It was done for 8 days. So this was done for 8 days. Then the third phase, they also included the a polyherbo mineral preparation, which is including the Sharapunka, which is Tephrosia purpurea, then Bhumia malaki, and the Shweta parpati, which is made from the following three ingredients, that is Navasara, then that is Suryakshara, and then Spatika, which is alum. So they have used these three ingredients, and in a classical textbooks of Ayurvedic Rasha Shastra, there is a preparation where you heat all these three ingredients, and then when they melt and become a amalgamated hot in fluid, or a molten liquid, you pour it onto a leafy surface. Usually plantain leaves are used, and they come they press it in between these leaves to allow it to become like a flat thin flake, and that's why it's called parpati. And this Shweta parpati, which is having these three ingredients, the chemical composition of each one of them is also given. So this is what is administered along with Punarnava Adika, Kashaya. Okay, so they are doing this phrase three, looks like somewhat Shamana Chikitsa, Samshamana Chikitsa, and Vyadhi Pratyanika Chikitsa, somewhat like that. They have chosen in phase three. Then phase three also includes one single herb, that is Bringaraj. The rationale behind this has been not given by the authors. It could be that the Bringaraj is a hepatogog, and also shown that it can reduce the oxidative stress, and it is a slight mild diuretic. That could be the reason why the authors have chosen Bringaraj as the single herb, Ekamulika Prayoga, that they have done. That is just the 3 grams of this herb, fine herb powder, is administered twice daily. So that's what has been done. So phase 3 has 3 modalities or formulations. One is a single herb, that is the Bringaraj. Second one, they have used Shweta Parpati with Sharapunka as one of the ingredients, and then Bhumi Amalaki as the second ingredient. And then the last among the third, the polyherbal formula in the third phase is the Punarnavadi or Punarnavashtaka Kashayam. So that they have done. Now that is the phase 3 part of the intervention. Now phase 4 is also very unique. So there are a lot of interventions. That's where the methodology that is out there in the mainstream, we cannot directly adopt to Ayurveda, because Ayurvedic interventions are like this. In this study, you have to do 1 phase, 2 phase, 3 phases, but the authors have done an excellent job in concluding everything that is so important for each phase of intervention. So the fourth phase is, now the patient was given, all the patients were given kshira, means milk. They took fat-free milk. Considering that these patients are going through liver issues, they have taken fat-free milk and administered it, and each patient or the participant can drink to the capacity that they want. They have given a certain amount of milk, and they could drink whatever they want to drink. So that is done. They have said that any varying from 2 to 3.5 liters of milk was given. That is usually, they have saying that boiled pasteurized milk that is fat free is being used. Again, in the classical textbooks, there is only kshira, that is daroshna, or coming from the udder of the cow, is being used. But here they are using the best possible milk preparation for the intervention. So there are 4 phases. The last phase only diet, that is ahara, with the milk and rice. Okay, so outcome measures. So after the weeks, the baseline to 7 weeks, what did they observe? So these are the outcomes and also results. you can see that the abdominal score, right, from the baseline so the baseline is VO here, and then the week 7 is V1. You can see that a mean score of 83.87 centimeters, right? It is a significant p-value, less than 0.01. It is a considerable amount of reduction in the edema. Second thing is loss of appetite, that is also improved. General weakness, it has gone down to some extent, not significantly, but it is, p-value is quite, impressive. Then we have the nausea, vomiting, and abdominal girth. If you look at the abdominal girth, that the authors do a very interesting write up in the beginning, saying that the maintenance of or the treatment of ascites involves a large facility cost. I mean, the people cannot do extraction of peritoneal fluid just in OPD setting. They have to go to a hospital, get admitted in a hospital. They have done a cost analysis, and they have said how much cost it is going to cost for doing a surgical, tapping of the abdominal, the peritoneal fluid, compared to this, how with the simple intervention, the girth has come down, the abdominal girth has come down. If you can look at about close to 15 centimeters of 15 to 20 centimeters in some cases of reduction in the girth, which is very, impressive. Then the urine output is also seen. If you look at the urine output, it is 266% improvement in. Sometimes I felt like, is it really true? That kind of impressive, results. Okay. Then the second outcome measures are the laboratory investigations that they have done. They have done it for the serum bilirubin, serum albumin. Then they also have alkaline phosphate. They have, I think, done the hemoglobin, SGPT, SGOT, of course. So they have done all of these, and you can see that across all these numbers, there is a p-value that is significantly improved or significantly changed, right? P-factor. Another thing that they also did is what they have as the child and the PER score, the child and PER score. They did the grouping. You can see here, I will read out very slowly for you. So at the base, 90 patients were graded as group C. That means worst prognosis. 36 patients were graded as group B. That is medium prognosis or non-complicated prognosis. Last one is group A. Only one patient was best prognosis or least complications. After the treatment at V1, when they put the child scoring, they saw that the first group, which was the 50 participants, had moved from group C to group A. That is, among the number of participants, I don't want to go into detail into what is the child pug grade, grade scoring, and what does it involve, the quality of life, etc. But if you are interested, you can definitely do that. You can look into this, a score that is done set as the child and pug score. But you can see 50 patients moved to group A, 6 moved to group B, and none were in group C. That means people with worse prognosis were not seen at the end of the intervention. Now, the study participants, they also mentioned what kind of participants, from where they were having these liver complications. They have given, the authors have given the N68, distribution. So prolonged alcohol consumption, say 26 participants. Alcohol with Hep B were 6 participants. Hep B alone, 8 participants. Hep C, 2 participants, and then the cryptogenic cirrhosis, about 26 of them. So we have like the, across the board, different types of the liver cirrhotic causes. Now, 12 of them, they say that they dropped out not because of study reasons, not because of the intervention, but of personal reasons. They said that some of them could not stay that long, and some of them had some personal things and they could not. So that's what the authors are mentioning, why the N68 turned out to be N56 at the end. Okay. Then prescription medication, the I was wondering when I was reading through this, if these many complications, were they not on any prescription medications? They were. The authors mentioned that they were taking the furosemide for the fluid retention, spironolactone for fluid retention, for improving the kidney function, to reduce edema. Some of them were kept on the same medication, not altered, no change. The one of the things is how long these patients were on these medications has been not mentioned. Whether they were just started taking it, that is one of the shortcomings that I found when I was reading this study. So their dosage was gradually reduced according to the decreasing edema and the abdominal growth. So the dosage, when they started noticing the patient was reducing fluid retention, they reduced the prescription medication as well for the furosemide or the spironolactone. So let's get into the discussion part of it. So in this study, improvements in clinical features and laboratory parameters were observed. So in all categories, all groups, like laboratory investigations, subjective parameters, objective parameters, and also child per grade scoring, everything seems to be making a positive inclination. The results were clinically relevant and statistically significant. Notably, albumin synthesis was initially impaired in all cases, but under this Ayurvedic treatment protocol, albumin levels increased in all patients. So that could be like osmotic change in the blood, and then even reduction in the edema could be seen because albumin is now being properly regulated. Ascites could be reversed and controlled. So this is the positive impression of this study. None of the patients developed severe adverse effects, new complications, and hence the treatment is found to be safe under given conditions. So they conclude that there were no complications in any of the patients that were recordable. Okay. Limitations. The authors, this is the part I like. What the authors have done is, these are the results, these are the evidences that we have, but we also know that there are limitations. The study is a non-randomized, uncontrolled, single group, open label observation. So what is an open label observation study? Is that both the doctor or the experimenter and the participants, both of them know what they are taking. So that's an open label study. And I have one last slide that I want to tell you. Sometimes an open label study can be a good study for Ayurvedic intervention. Some of the, depending on what type of a design that a scholar is trying to do. And then we are seeing that this design, therefore, bears a major limitations, various non-specific effects. The setting and the time course may have contributed to a beneficial course of disease. Thus, they may have influenced the result. So, because of control, problem with the control, seems to be a flaw, or they are saying that it could be something that could be a negative against the entire study. Furthermore, changes in the diet, restrictions in the alcohol consumption may have influenced the results. Right? That's what the beauty of this, entire study, that they are giving where are the shortcomings, and also they say this could be done as a randomized control study there in a larger population. If the study therapy, therapies would have been studied with more patients under control or randomized conditions, then the effectiveness of these therapies can be accurately measured. So another limitation is that the patients with serious complications like severe gastrointestinal bleeding, hepatic encephalopathy, these were not included. So that would influence the child pug score, right? So that's what also the authors are saying. In conclusion, on the basis of these findings, Ayurvedic treatment protocols could be potentially safe and effective complement in case of the hepatic cirrhosis complicated with ascites as a therapy. If complicated in larger, I mean, if replicated in larger trials, Ayurvedic medicine could have a promising, tool, can be a promising tool, and then can postpone possibly the fluid tapping or the complications of fluid retention and ascites and such things, and improve the quality of life of the patients. So this is a recent thing that has been done by the Kahan and then the Jairat. These two authors have been doing a lot of fundamental studies on the reducing bias on open label studies, and they're saying that some studies, in given a scenario where you cannot have a control or a RCT, then the open label study may be the right answer. That's what they are concluding in their study. This was published by BMC, and it's a very interesting study too. So something that we can consider, that as Ayurvedic researchers and scholars, we should be not clinging on to the RCT as our main proving factor. There are other methodologies like evidence-based. Even the open labels trials can be taken as one of the positive outcome studies in Ayurveda. Thank you very much.
Thank you, Dr. J. Very interesting study, definitely. I definitely have some questions, but I will let the others chime in first. Dr. Anjum, nice to see you.
Hello, Dr. Pratibha ji, Dr. Ram, Vandana ji, Meenakshi ji. Very nice to see you all.
Anybody has questions? Otherwise, I can ask. No problem.
I feel the choice of the herbs is really good, and Bringraj was the one which was really out of the box.
Yeah.
So it has the liver hepatoprotective properties, as well as Bringraj works very well when it is the cirrhosis of liver, as compared to even the Bhumya Malki. Bringraj has the ability to regenerate the liver, as per the clinical research and the chemical composition of the Bringraj. But then also I feel there are certain areas where they could have focused more, like they have taken the kutki as a virachan dravya. That was also interesting study, but it is like all over various factors they have put to, where it is not concluded to 2 or 3 herbs, or like the milk also, for example. I remember when I was in BMS doing the clinical internship, that time our teacher for ascites case, he used to give the patients only the DW, which is a distilled water injections, and put them on the camel milk or the cow milk, depending upon what he sees, for at least 6 months to 1 year. And the results were very promising. No other herb, only that one. And later they did the clinical trial also. So in that way, yes, it is like everything they have combined together for this clinical trial. Yeah.
Yeah, I think if we look at the current Ayurvedic practice, this is the type of practice that we find where there is a little bit of classical touch to it, but also there is multiple interventions being put together. But also considering the seriousness of these cases, I think there was a need for doing multiple interventions. One single herb would have been difficult to prove the efficacy of these interventions.
Yeah. Dr. Vanna, you want to say something?
You're muted, Dr. Vanna.
This thing is like it catches us. So it was a wonderful presentation. Actually, study is complex. So many interventions, like everybody has observed here, and approach is also unique. Selection of patient is also unique because they have allowed liberty of various things at highly individual levels.
Yes.
Which are not measurable according to the modern parameters also. So it is a complex study, but you have presented wonderfully. I didn't get the chance to read it before, but I was going through your presentation. I saw that you have made it very interesting. On my own, I wouldn't have been so much interested in this study because it is complex, as the first name of the title itself. In my MD period, I have seen in my Khai Chikitsa department use of Vardhaman Pipali Rasayan for Jalodhar patients, and with wonderful results. Actually, the patients used to come because one of our teachers used to use this Vardhaman Pipali Rasayan on Jalodhar, and it was kind of end of the treatment in the modern side, because I have done from BHU and we have both hospitals side by side. So it was kind of history and reputation that anybody reaches there, they used to be shifted to the Ayurvedic ward with wonderful results actually. And I have seen good results in elderly patients. One of the patient I have seen was more than 60 years of age. So, but here this study have involved so many things. So wonderful selection, I would say.
Thank you. Yeah, the purpose is, the entire thought process behind selecting this study was to encourage that not all studies need to be at the level of what RCTs are. Even studies done like this carry a lot of value. So that's the purpose of it. And I think another way of looking at is the researchers looked into what all the previous studies that have been done as for either for ascites or maybe hepatitis or complication cirrhosis, and they have chosen those all 3 or 4 interventions and then made into a multi-facet approach. It looks like it, because Bringraj, there is a study. I looked in, there's a study on Bringraj for, hepatoprotection in alcoholic liver disease. And there's Vardhamani Pipali Yoga as well. So probably that's what they did. And they put down all these with the previous, studies. I'm just speculating at this time. I'm not sure whether the authors did that, but it looks like it.
Yes, the communication is not very clear about the dose, about the investigations. So it's kind of confusing when I'm going through this study, I couldn't make it out.
Yeah, I spent some time and looked at the phases. Then it made sense, because first they mention the phases and then they have the intervention. So that's why it's a little, complicated. Yeah.
You want to say something?
Yeah, Dr. Ram very well presented, and it was like by the Dr. Vandana mentioned, by the name itself, I thought it's a very complicated and like looks like a very something it's difficult to understand, but you made it so simple and nice to follow.
Thank you.
It was a good study. I enjoyed it.
Thank you.
All right, I'll try to summarize and also share some thoughts. So I think one of the things that is a hot discussion in Ayurvedic research field is that RCTs are definitely not appropriate to measure Ayurvedic interventions. They're not ideal. The template is not suitable because Ayurveda is usually polyherbal, and there are many different interventions that we are using, including just the meeting with the Ayurvedic professional, where there is more listening. That is considered an intervention on its own. There are studies on that alone, where we all know that, oh, doctor, by just speaking with you, 50% I'm feeling all right. So that's actually considered an intervention. So that is, I think, definitely a very vast, hot discussion, that RCTs are definitely not the gold standard, definitely not for Ayurveda. I would go by what Dr. Oliver Sacks, you can all look him up. He was a very well-renowned physician who recently passed away, who was a big advocate of case studies. So here at CAR also, we have always been saying, if you go on our website also, under the resources, you will see how to write a case study, how to present a case study, because case study allows you to report as is. You don't have to worry about, what was the standard or blinded or randomized or control was there or not. Case studies are meant to be reported as is. So that's beautiful. Now, coming to this study, I personally felt it was very scattered, because the rationale has not been explained. Why, what has been picked up? Number one. So, as you mentioned, that probably certain success stories have all been put together. It's like a big soup pot, throw in everything. And if you see the inclusion criteria, three types of cirrhosis have been included. One is alcoholic, one is infective hepatitis led cirrhosis, and the third one is the cryptogenic. And all three are different. Now, the approach for all three is actually very different. So, just because they have not explained the rationale behind picking up, this is a big gap actually. Second, their flow of writing the case study is not succinct, it's not clear. I'm just being critical because that's the job of journal club. So don't take it, nothing about you, Dr. J. It's about the study basically. The flow is not very good, because 2007 to 2010, it's a very long period. People can die in that period. Their lab reports can change. So they have not specified if this was like a ongoing trial, where as the patients were coming in, they were giving them the same standard protocol. And it took 3 years to sort of complete the last patient. But it was 6 months, means 24 weeks. If 24 weeks is 6 months, so that part is, I think, pretty straightforward. 6 weeks plus 18 weeks is 24 weeks, which is 6 months.
It's
So
5.5 months.
yeah, if you 5.85 months probably, because just a few days will be a little bit extra
I
probably.
think there was they did not put together, like I could not calculate where there was that 2 weeks missing. Where did it miss?
How
But I
are
think
you calculating the 2 weeks? Where are they coming from? Because each
maybe there
month
was
has a little more than
there
4.
could be a gap in between when they were doing the phases. After the phase, when they went back as from IPD to OPD, probably there was a gap of 2 weeks, which was not any intervention.
Yeah. So yeah, I mean, there's not a very good flow, I would say, in the whole thought. I mean, in their heads, I'm sure they had a thought process. But when you write a paper, the whole idea of writing a paper is you're conveying, this is how we thought. And you have to mention the rationale for picking up. Why did we pick up Vardhaman Pipali Rasayan? Why did we pick up the Shweta Parapati and all that combination? Why did we pick up Punarnavashtak Vatam? Against
There is an
maybe.
explanation,
Mhm,
Dr. Pratibha. The authors have done
mhm.
the explanation. When you go through the entire study, they will
Okay.
say, why did they choose Punarnavashtaka Kashayam? They are
Okay.
saying that Punarnava has these active principles in it. They have done that.
Okay.
There is
Okay.
a rationale and also scientific backup for why they have chosen. In
Okay.
the entire script you will go through.
Even for Vardhaman Pipali also?
Everything. It says why people is being chosen, what are its active principles,
Okay.
everything.
So in this particular journal club meeting, we were not able to get the study. So we will be I was also reading on the side as you were. So okay, thank you for clarifying that. And I think last but not the least, I just want to comment that this is again a very, I mean, in general, I felt that because this was not clear how they were approaching these different types of cirrhosis, because in the infective cirrhosis, viral load is a very important criteria. And viral load, nowhere it was mentioned, only liver function tests were mentioned, and the child pug scale was mentioned. So that part I felt, because after 6 months, how is the liver doing? Like, what is the ongoing exit protocol for the patients? A little bit like it's a little open ended. Okay, we went and did something, but what did you leave the patient with? So little bit, these little things, I felt like it was a little not very well expressed paper.
Yeah.
There are there is room for yeah. Go
Yeah.
ahead.
So when it comes to probably the viral load, it is not uniform across, like they cannot measure the viral load on the alcoholic liver disease. They could not,
That's
or
what I'm
for the
saying.
cryptogenic, they could not. So
That's what
they
I'm
would have
saying.
left it. Maybe there was a reading, but they would not have considered it as a, parameter or measuring parameter.
Yeah, but what does it say? Like in 6 months, you can give it to any type of hepatitis or ascites with cirrhosis. Uh, but then what? Like, what are we trying to say here?
Hmm.
That was a little open-ended, because again, because they have pooled all types of cirrhosis in one bucket. If you pick up alcoholic cirrhosis, then you can get clarity. Okay, we have this direction for that. But alcoholic cirrhosis is very different from infective cirrhosis, because infective cirrhosis, the period can be, different of the, the development of the cirrhosis from the time of infection. So little bit, these are the small things which, where we Ayurvedic, when our fraternity, when they write papers, this appears very broad. Honestly, yeah, if you see, if you read or listen to some of the previous, some really good case studies, even Dr. Anu, I think she has presented, right? How many, 3 months back, probably. Those some of the studies are really model studies, where the authors have taken care of all of these things. So I'm sure they had a strategy, but they were not able to convey in the paper. And that is a little bit of a shortcoming, because it leaves you with not very clear answers. It shows that these interventions are bringing down certain parameters, but how do you apply that in treatment in real life, for different types of cirrhosis? That direction is probably, again, I'm going to read the paper later on, because it is interesting. Definitely the interventions are also interesting. And I was actually going to comment on the milk also, that we usually give camel milk, that Dr. Meenakshi also mentioned. So it was interesting to see fat free cow milk, which is understandable that this is a compromise that's done, because the liver is incapable of processing fat, probably, in that condition. But it was an interesting choice. That also, I don't know what was the rationale for it, but maybe it's a good Anupana, uh, fat free.
If a very orthodox Ayurvedic practitioner is presented with this research, there will be a lot of strike marks on this, because not much authenticity can be found in it. So that is a shortcoming of these study, that the interventions that I have chosen. But there are probably the researchers' mindset was, let's see how we can show that Ayurvedic protocols work.
Right.
Yeah, that could be the major drive behind this type of a poly intervention.
Right. I mean, I totally agree. And these are encouraging results. I mean, the p value is so significant. P value is significant in all of the types of interventions. So that is very, very encouraging. It's just that it's a responsibility also to convey in the paper, like what was the thought process, even the period. Vardhaman people, why only for so many days? Why not for more days? Like how did you determine that? If you put it on the paper, it makes it a little more authentic of this was the thought process. Then maybe it can be built upon. But right now we have no preview of the thought process that went into deciding all this. So yes, I mean, there are great things about the paper, but again, it's going to be taken apart if it's presented in the so-called scientific community for all of these reasons. There's a little bit of intellectual laziness in presenting the paper. That's the feeling I got, that it was just whatever, all the good, nice things were presented, but what were these stringent, like objective thought process behind selecting those time periods, those dosages, those frequencies, that I wish they had shared. It would have made it really strong then.
Yeah, if you read through the discussion part of it, the authors have done justification for what they have done, why they have done.
All right.
There is a justification. To some extent, they're saying that there are these flaws in this study, but also they are agreeing that this type of a study. Have you seen the rheumatology study that was done through UCLA? With the AVP and UCLA together, they also had this type of a factorial intervention. So there some of them were given just the medications, only the Shamanaushada. Some of them were given Shamanaushada and Panchakarma. Some of them were given Shodhana, Shamana and Panchakarma. So they had done that study. That is also one of the most well-known studies in
Ram Manohar, right? Dr. Ram Manohar?
Yeah, Dr. Ram Manohar and AVP.
Yeah.
So that study also looks like this. I mean, as Ayurvedic doctors, we are researchers, we have to have that open-mindedness to see what best works for this type of investigation we are trying to do.
I think that study was documented very well, though. With all the, there was a very good flow, there was clarity. Wasn't that what Dr. Anu presented probably? We have seen that study.
Osteoarthritis. That was a rheumatoid arthritis. So Anu was
But we know about this study because this was landmark. I think this is the first time NIH had given funding for an Indian study.
Dr. Ram Manohar was the Indian counterpart, a principal investigator.
I think what we're trying to achieve through CAR is also not just the work, but how do you present it? Because presentation is so important. Absolutely. Yeah, so that's why we try to kind of highlight those aspects also, because I'm sure all of us are doing great work. We get the outcomes, but how do we document? And second, how do we present the documentation is really important in getting us to the place we deserve. So I'm trying to just put on those glasses and lenses when I'm saying whatever I'm saying.
Sure.
But really good. Thank you so much. And thank you everyone who has attended. And I'm sure this will be watched later on. It's a little odd time, so we don't have a great attendance today. But I'm sure it will be watched later by many people. So thank you, Dr. J, for coming and presenting. Thank you so much.
Thank you for each one of you. And thank you for CAR for inviting me. And I enjoy presenting. Thank you very much.
Thank you. Thank you. Good night. Good night, everybody.